very interesting case. This is a patient who presented to our hospital with decompensated heart failure. In fact, biventricular failure. He's 59-year-old, non-frail, independent, and he has a long life journey of valvular heart disease. In fact, the primary etiology is rheumatic valve disease, and he underwent 4 previous surgery with aortic and mitral valve replacement. The last one about 20 years ago, and now he's very symptomatic. The EUR score and the STS score are not so high. That's very interesting because this is a patient with multiple previous surgery. And these are the lab tests, as you can see, pretty normal, including renal function with GFR of 98. Liver evaluation was also normal. And as you can see here on echo, he has a preserved ejection fraction of the left ventricle, 59. He has aortic bioprosthesis dysfunction with severe aortic regurgitation. The mitral bioprosthesis is pretty normal with mild stenosis, but this patient has a massive tricuspid regurgitation. The pulmonary systolic pressure was estimated in 49 millimeters of mercury. And he has also a tricuspid annulus dilation, 49 millimeters. The right ventricular function is well preserved with ejection fraction of 52, a TAPSE of 17 millimeters. We discussed this case in our heart team, and in summary, young patient, very symptomatic with multiple previous surgeries, and now with severe bioprosthetic aortic dysfunction and a massive tricuspid regurgitation.
Wow, Dimitri, what a case. You just presented a case. Rheumatic disease is still a problem of the daily basis in many parts of the world, and that happens also in Brazil, in Latin America. And this patient underwent 4 previous surgeries. Now he has a very dysfunctional aortic processes and also a mechanism of dilated tricuspid valve, right, dysfunction, and leading with a progressive worsening of its symptoms. So in a patient like this, in a situation like this, is surgery the first option of treatment? A 5th operation will be the first attempt to treat both valves?
Well, Ricardo, despite the scores, the STS and the EUR score 2, we consider this patient a very high-risk patient for reduced surgery with a high mortality. If we think of operating also the tricuspid, so it's going to be combined surgery, aortic, tricuspid, and probably the mitral, because the function is normal, but it has some thickened leaflets and calcifications. So
it's a very borderline condition,
right? We deem that this patient is high risk with high mortality and higher rate of complications, for example, bleeding due to multiple adhesions of the chest. So it's a very tough case for surgery.
And from the percutaneous point of view, could we also offer possibility to treat the aortic dysfunction, prosthesis dysfunction, as well as tricuspid? And in this case, what will come first? Because it's difficult to say, right? What's bringing this patient to adding more to the dysfunction that he's having in terms of the clinical presentation right now?
That was our decision. We treated the aortic bioprosthesis dysfunction last week. We're going to show you the images.
So the intention was to treat, first approach the aortic bioprosthesis dysfunction with a TAVR. And then following, you could deal with the tricuspid.
It's feasible to perform both interventions at the same stage. Okay. But our decision is to first perform valve-in-valve, aortic valve-in-valve, and we did
to get some level of compensation,
and then we now we are gonna treat the tricuspid.
Okay, so what you did last week?
This patient, he has a biocore 25 millimeters, so we decided for valve-in-valve with a self-expandable valve. We implanted Evolut R26. We did a post-dilation with a non-compliant balloon, and this was the result. With minimal peak gradient.
Just a great result, yeah.
And good angio.
In your experience, is there a preference for a self-expanding versus balloon expandable valve in a situation like this?
It depends on the anatomy. I think in this case, maybe a balloon expandable valve could also work very well. The biocore is 25. But if this patient has a smaller bioprosthesis, maybe a self-expandable valve could be a better indication for improved hemodynamics.
So what are the options in a situation like this to deal with the tricuspid? You just showed a massive tricuspid regurgitation.
I think that we have good solutions out there. We have the possibility of performing a transcatheter edge-to-edge repair on the tricuspid with TriClip or Pascal. Some dedicated transcatheter heart valves for tricuspid that are under investigation. But all the device has some anatomic restrictions.
Okay.
And this patient, for example, he has a huge gap on the tricuspid leaflets. The atrium are very enlarged.
So that's a limitation for some of these technologies, right?
So, and in Brazil, the only approved device for transcatheter solution for tricuspid is the Tric valve.
I will ask Alberto to speak a little bit about the technology as you guys are working.
So it's a Bicaval valve system. It's made of two valves, one for the superior vena cava and another one to the inferior vena cava. So it's designed to treat the severe tricuspid regurgitation without touching the tricuspid valve. So
that's why you call heterotopic, right?
That's heterotopic. Yeah. So as you can see in the image, we have data with midterm follow-up that it avoid the backup flow, reduce the congestion, promote the right ventricular remodeling, increase the cardiac output, and reduces the symptomatic, especially the right ventricle. So
this is the mechanism, right?
Yeah.
This is the mechanism. Okay.
So how do we select the patients? We have the clinical parameters to select the patients, especially the severe symptomatic with tricuspid regurgitation, with functional class of New York Heart Association 3 or 4, despite of the medical treatment.
Okay.
So by the hemodynamics, we can use the vena cava, the atrium pressure of 15 millimeters. The valve has the crown that you use the innominate vein to position the valve. And we have the belly that will be anchored the valve. And we have the leaflet working a little bit down. So for this case, we choose the 25 millimeters superior vena cava prosthesis. The valve has the valve functioning upper, and we have a skirt and minimize leak. But this skirt, we have to put a little bit higher than the hepatic vein to not occluding the hepatic vein. As you can see there, we are going to place a catheter in the hepatic vein to use as a marker to deliver the valve. For the inferior vena cava, we choose the 35-1 because of the measurements we did before.
And we just got access here. Okay. Ultrasound guided venous puncture of the femoral vein.
Okay.
We already did a pre-closure with 1 proglide.
So the expectation is to use what size in terms of French size?
27 French.
And 1 pre-close is enough?
Yes.
Okay.
And on the left side, we got 2 access Generally, we only need one, but in this particular patient, because of some anatomic characteristics,
Okay.
we're gonna put a pigtail on the pulmonary, right pulmonary artery, as you see on angio,
Okay.
and the other one, we're gonna put in the innominate vein.
Okay.
This patient has a large confluence of the superior vena cava to the right atrium.
Okay.
So we need to be cautious about positioning the superior vena cava valve.
Okay.
And we're gonna need some injections just to realize if this is a good position
Okay.
for the superior valve.
And you mentioned, Alberto, this will be approached as a minimalistic approach for this patient, for this gentleman. What does that mean exactly? Please,
We actually
operators.
just need the thoracic echo to guide us, because in the superior vena cava we have the landmarks to positioning the bioprosthesis, and in the inferior vena cava the thoracic echo
Yeah.
can help us to see the inferior vena cava and the right atrium.
So, Dimitri, what are you doing now, please? If you could just
Yeah.
let us know.
We just placed a stiff wire on the superior vena cava.
Okay.
We're gonna use a Lunderquist wire.
Okay.
And we are dilating the axis here with a 18 French sheet. So based on CT measurements, we choose 25 valve, right?
25.
So it comes very easy.
Okay, so it's going smoothly here.
We need to place this valve with the belly above the pulmonary artery catheter.
So the peak catheter here in the pulmonary vein, that's your marker there.
Yeah.
That's your landmark there.
Yeah. And Alberto is gonna start the release of the first valve.
Yeah, with a really slow deployment.
Very slow.
Sometimes we need to correct the parallax of the valve.
If you have a partial deployment, can you recapture and deploy again?
Sure. We
And-
can do it about 3 times. We can recapture until 80% or 90%.
Or until 80 to 9%. Wow. So this is very helpful to achieve precise delivery. Can you explain here for us the position here?
As you can see here, in fact, I think it's a little bit high now. Maybe we can pull the valve a little bit
And where do you want the belly exactly?
above the pigtail that is in the right pulmonary artery.
Okay, so you have some room there, right?
Yeah.
You can see the opening very smoothly. Now we see the belly in the mid portion. So when you say the size of this valve,
That's the
is
one on
that
the angel.
related to the proximal, to the distal, to the belly, Dimitri?
To the belly,
To the belly,
point
okay.
of anchoring.
As
is
anchoring point,
the belly.
okay.
Yeah, we perform this procedure with full anticoagulation.
Okay.
We gave him 100 units per kilo.
Per kilogram, okay.
We are reaching the no
Okay.
capture.
So now you
recapture
see the
point.
belly here, it's quite open. Are you ready for full release?
Yeah. We
Okay.
are doing that. As you can see here, all the hooks are already deployed.
You can see 3 of them.
The valve is free.
Okay, so 3 anchoring points here. Okay.
So, and now we need to pull the nose cone. Let's
That's
pull
important.
it very slowly. Sometimes we need to play with the wire,
Okay, just to make sure that you're not.
interacting with the prosthesis.
Yeah,
right?
yeah.
Very slowly, very slowly.
Okay, okay.
So now we are ready for the inferior vena cava valve.
So we are advancing here. The IVC prosthesis now. Again, everything guided here by angio. So you don't need the pigtails anymore. You just need the catheter, the multipurpose catheter position at the hepatic vein.
Yeah.
Can we have the echo, please?
The goal here, Ricardo, is to minimize the protrusion of the valve inside the right atrium, up to 8 to 10 millimeters.
Okay, maximum 8 to 10 millimeters. So I was just wondering here, if a patient has a pacemaker, is this a problem to deploy this device? Is this a limitation?
I don't think so. I think this is an
Like a permanent
advantage
pacemaker?
of the device. There's no interaction with the leads. Obviously, we measure the parameters of pacemaker before and after trick valve implantation, but generally this is not a problem.
So Tito, you want to show us here, tell us exactly what you're seeing there, and maybe to appoint this to the ones who are following us here in this procedure?
We are seeing here the processes in the catheter. So we just need to show them the distance that we are inside the right atrial, just to find a great distance for them, something around 8 and 10 millimeters from the origin of that.
As you can see, the hepatic vein is drained to the inferior vena cava. We have the open cells region marked by the light bands.
Okay.
So I think we are good to keep going.
Go ahead. Let's do an angel here, just see the...
Okay, so
you can see that the upper part of the valve is above the hepatic vein.
okay,
As you can see here, just inside the right atrial, just a small amount of the processes, and a little bit in the ostium of the hepatic vein without any problem.
yeah.
It
So
doesn't.
Dimitri, here you in this position, you feel comfortable, you just continue to release,
Yeah.
control by echo, control by angio, and also
You can notice, Ricardo, that we pull the wire.
yes, I did
Also,
see, yeah.
because if there is some angulation with the superior and the inferior vena cava, you can have some
That will not affect,
difficult-
right?
Yeah.
Yeah, you can cause some, yeah,
Go ahead.
you can be too protruded, right?
Yeah.
Because of the angulation.
Go
So
ahead. Go.
you are continuing here,
We don't need to
The
correct
release.
the parallax.
and as you pointed, Alberto, just the transition there
Yeah.
is exactly
Open
well-
cells to closed cells.
open to close cells, so
Let's do an angel
that's
here.
your marker there.
Go ahead.
Okay.
Slowly.
So slow.
Oh, it's
And you keep pulling a little bit,
keep
right,
pulling,
Dimitri?
keep pulling.
All the time. So
Yeah.
that's very important. For me, it appears to be a perfect position, right?
Yeah.
Just perfect, right?
Yeah.
You see the upper open cells just at the level of the hepatic
Go
vein.
ahead. Go
You
ahead.
see a transition, and you see the closed cells
Yeah.
just distal to the level. So you are safe
So-
here.
Yeah. So let's measure again by echo.
we can see here just a tip of the process, 80 millimeters inside the right atrial,
So Dimitri, you said about 8 to 10
Yeah.
millimeters, right? So just
Yeah.
8.
maybe a little.
Very precise. Perfect positioning.
Go ahead.
Yeah,
Yeah, hand.
Go ahead.
and we can see an obstruction of the hepatic veins. Regular
Okay.
flow.
Okay.
That's okay.
So Alberto is continuing here. You just released, right, Alberto?
Yeah.
Yeah.
So it's fully relieved. You remove the multi-purpose catheter.
And a small paravalvular leak here, as you can see in the screen. I can show you with this
Colocar
arrow
pigtail.
here.
Colocar só para medir a pressão com pigtail.
As you can see
Okay,
here,
so
this
big
flow.
Yeah.
But the hepatic vein is the preserved flow and
Okay.
nothing
Esse é o
after
inferior.
this
Medir a pressão.
paravalvular leak.
Do you think it's small paravalvular leak?
Yeah, it's a mild one.
But I think
But I
it's
think
a
it's still
very
yeah,
reasonable
yeah,
result.
Yeah, reasonable position. Yeah.